Good afternoon, my dear professors and senior colleagues. Today we'll be discussing anterior segment introduction. The anterior segment had been divided for ease of discourse into the cornea as a separate entity, uveitis as a separate entity, then the cataract as a separate entity, so it will be easier to be discussed. So today we'll be discussing introduction to the anterior segment in terms of cataract. The human eye itself can be divided into two segments, the anterior segment and the posterior segment. The anterior segment consists of the crystalline lens and every other structure in front of the crystalline lens. That means anatomically, the anterior segment starts from the epithelium of the cornea to the posterior capsule of the lens. Now, the structures themselves will include the cornea, as I've mentioned, which will be discussed separately, the iris, the anterior chamber that houses the aqueous humor, and the posterior chamber. Then the lens itself, consisting of its capsule, the cortex, the nucleus, and the posterior capsule. The anterior chamber is bounded anteriorly by the corneal endothelium and posteriorly by the anterior surface of the iris diaphragm, and also the anterior part of the ciliary body. In its deepest part, which is the center of the anterior chamber, it measures about 2.5 millimeters, and the other parts of the anterior chamber are not as deep as the central part of the anterior chamber, and is slightly shallower in hypermetropes and also slightly deeper in myopes and those who are aphakic. It contains about 0.25 mils of aqueous, and it communicates with the posterior chamber through the pupil. Now, it's important to know this because the central portion of the anterior chamber is the safest zone for manipulations during cataract surgery, and that is why it's important to always reform the anterior chamber. Now, in cataract surgery, it's advisable that if you need to reform the anterior chamber, you should make it deeper than you made it, because by the time you introduce instruments into the anterior chamber, likely some of the viscoelastic solutions will be lost, and by the time you are done with your manipulations inside the eye, at least you still have a sizable depth to work with, so that instruments will not touch the corneal endothelium. It's always important to remember the apparent and the real depth because of the difference in the refractive indices of the structures before the anterior chamber, so that one will not introduce instrument into the anterior chamber and mistakenly think he or she is in a deeper position, while in real sense the person is close to the corneal endothelium. And why during cataract surgery it's advisable to be careful as one is doing cortical cleanup to avoid sudden shallowing of the anterior chamber, because that will make the corneal endothelium to hit on the instruments or to hit on the iris diaphragm. And also, by the time surgery is over, as one is closing up the eye, it's important to make sure that the anterior chamber is reformed adequately. Now, how adequate should that be? Well, no one accurately knows, but the best approach is to be sure that the scleral tension is just slightly firm enough. Let it not be soft as one is leaving the eye after cataract surgery. I, for one, I use air to reform my anterior chamber. Not just that, it prevents iridocorneal contact at 12 o'clock position when the patient is upright. So in all, it helps to prevent peripheral anterior synechia, especially in 12 o'clock position, because of iridocorneal contact. So in all, after cataract surgery, one should be careful to maintain the anterior chamber well formed. Knowing that aqueous to be produced, is not wise to reform the anterior chamber to its fullest, as one would consider it, depth, because aqueous is going to be produced. So you finish a good surgery, and by the next day, the cornea is so hazy because more fluid have been added for it to it from the aqueous, and you now have high intraocular pressure due to too much fluid in the anterior chamber. So after cataract surgery, it's advisable for one to minimize full reformation of the anterior chamber, but at least make sure there's a sizable depth. I use air to reform, it's safer for me. Some use visco in difficult patients, while some just use ordinary saline. Saline is not the most comfortable means for me because most of my patients, when they squeeze their eye, the saline is off. So, but if I put air, no matter how much you try, the air still remains, and it gives you clear cornea the next day. There's nothing as good as removing plaster 2 hours after surgery, and the patient is so happy because there's clear cornea and the air has gone above the pupillary margin. The iris is a contractile pigmented diaphragm with a central aperture which we call the pupil. In the anterior-most part of the uvea, it is the anterior-most part of the uvea tract and is suspended in the aqueous humor between the cornea and the lens. The iris diameter is about 12 millimeters, whereas the pupillary diameter varies from 1 to 8 millimeters. It divides the anterior segment into two chambers, the anterior chamber and the posterior chamber. The anterior surface of the iris can be divided into ciliary zone, which contains the crypts, that's depressions where superficial layers of the iris is missing, and the pupillary zone by a zigzag line called the colarites. Microscopically, the iris consists of 4 layers. From anterior to posterior, there are the anterior limiting layer, which contains the melanocytes and fibroblasts and to define the color of the iris. This layer is deficient in areas of the crypts. After the anterior limiting layer, we have the iris stroma. This consists of loosely arranged collagenous network in which are embedded the sphincter pupillae muscles, dilator pupillae muscles, the blood vessels, the nerves, the pigment cells, lymphocytes, fibroblasts, macrophages, and the mast cells. The sphincter pupillae muscles are found in the pupillary zone of the iris, supplied by the parasympathetic fibers from the cranial nerve 3. When stimulated, they lead to pupillary constriction. The dilator pupillae muscle are found in the ciliary zone of the iris, supplied by the sympathetic fibers from the superior cervical sympathetic ganglion. When stimulated, it leads to dilatation of the pupil. The third layer is the anterior epithelial layer. The anterior epithelial layer is the anterior continuation of the pigment epithelium of the retina and ciliary body. The fourth layer is the the posterior epithelial layer, and is the anterior continuation of the non-pigmented epithelium of the ciliary body. So we'll look at the ciliary body. Itself is a forward continuation of the choroid at the ora serrata. In a transverse section, it is triangular in shape. The anterior side of the triangle forms the part of the angle of anterior and posterior chambers. In its middle, the iris is attached. The outer side of the triangle lies against the sclera with the suprachoroidal space in between. The inner side of the triangle is divided into two parts. The anterior part measuring about 2 millimeters with its finger-like ciliary processes and is called the pars plicata, while the posterior smooth part measuring about 4 millimeters is called the pars plana. Now the ciliary processes receive attachment of the suspensory zonular fibers that keep the lens in suspension. The next we'll discuss is the crystalline lens, and the crystalline lens itself forms the posterior boundary of the anterior segment. It's transparent, biconvex, and can be seen through the pupil, and is in front of the vitreous body. Its convexity is more on its posterior surface than its anterior surface. The marginal circumference of the lens is sometimes called the equator, whereas the center points on these anterior and posterior surfaces are referred to as anterior and posterior poles, respectively. The adult lens measured approximately 10 millimeters in diameter and 4 millimeters thick. And if we now add the depth of the anterior chamber, which is approximately 2.5 millimeters, to the thickness of the lens, which is 4 millimeters, so the cataract surgeon has about 6.5 millimeters to 7 millimeters of depth to manipulate. It's advisable that every manipulation of the lens should be done within the bag, except if one is doing SICS or doing ECC and you need to escort the lens or the nucleus out of the eye. But if one is doing focal emulsification, it's advisable to do it in the safe zone of the eye. The safe zone of the eye in terms of cataract surgery is the center point, the central area, or some will say the central 3 millimeters to the central 4 millimeters of the eye. If you can imagine the original pupillary position, that will give you an idea of where the central safe zone of the eye is during cataract surgery. All manipulations should be done at the safe zone. Even if the focal tip goes to pick up a nuclear fragment, you still have to bring it back to the safe zone and fragment it away as much as possible, and safely also, from the endothelium and from the posterior capsule. The crystalline lens is made up of 3 parts: the capsule, which is elastic, the epithelium of the lens, and the lens fibers themselves. The capsule is thick, transparent, and it surrounds the lens. In terms of thickness, in children the thickness is virtually the same, but in adults the posterior capsule is thinner, and that's the more reason why, if you have reason to do primary posterior capsulorhexis, you need to be sure that the anterior chamber is fully formed to give you firmness. The firmness is what you need. If not, it will run haywire. But if it is fully formed, preferably if you are using cohesive viscoelastic solution, so it will be easier for you to just do a central 3 millimeter primary posterior capsulotomy. But in children, for those who do cataract surgery in children, the pediatric surgeons and the focal surgeons, we know that the posterior capsule is actually very thick in itself. And even if you want to use the the vitrectomy cutter to do the primary posterior capsulorhexis, it's called that it's thick. It takes some cutting power. You have to really increase the cutting rate for it to give you a very smooth circular cut. Or you can use your hand and just make a good 3 millimeter primary posterior capsulotomy. The epithelium of the lens is found only on the anterior surface of the lens. It is of the cuboidal type when it is in the central portion, but at the equatorial part it becomes columnar, and at the lens epithelium at the equatorial part are the ones that are actively dividing and elongating to form new lens fibers throughout life. And that becomes important because during cataract surgery, it's good to do a total evacuation of the lens nucleus, the cortex, and sometimes, if not always, polish the capsule up to the equator. Now, if there are remnants of the lens epithelium left at the equatorial part, they will still elongate backwards and cause posterior capsular opacification after surgery, after a presumed good cataract surgery. Now, this is commoner in children, and that's the more reason why it is advised that a good surgery, cataract surgery in children, must consist of the lens removal, primary, posterior capsulorhexis, and anterior vitrectomy. Anterior vitrectomy is better done through the primary posterior capsulorhexis instead of go to the pars plana, except for those who have reasons to go to the pars plana. I usually don't have reasons to go to the pars plana. I just do it through the primary posterior capsulorhexis, and it gives you a good, clear view after the surgery. Now, it's not advisable if you don't have facilities to do the three combination of removing the cataract, primary posterior capsulorhexis, and anterior vitrectomy. It's not advisable for general surgeons to operate on children because you would have finished a good cataract surgery just in a matter of weeks and months. You will now have thickened posterior capsule and also the thickened anterior vitreous face, which will make it look like you didn't do a good job. But if you have facilities and machines to do the three combinations, then it's possible to go ahead. So in my own view, I will advise, if you have a child that requires cataract surgery, please leave it for the pediatric surgeon or the phaco surgeons. They know what to do. Embryologically, the rudimentary lens is first seen as the thickening of the surface ectoderm, the lens placode, at the 22nd day of gestation. It overlies the optic vesicle. The lens placode invaginates and sinks below the surface ectoderm to form the lens vesicle. The cells in the posterior wall of the lens vesicle elongate to form the primary lens fibers. These primary lens fibers become attached to the apical surface of the anterior lens epithelium, and their nuclei disappear. So subsequently, all additional lens fibers are formed by the mitotic division of the anterior epithelial cells at the equator. These are the secondary lens fibers.